All right, here's the lecture on articulations. As I've told you before, this is one of the chapters that I think it goes into way too much depth in general. So I try to limit it, and the way I limit it is by saying, if I don't talk about it, you don't need to know it, okay? And I don't go through all of the joints. I just want you to learn some basic principles of how the joints work. And then I basically want you to know the knee and the shoulder. Those are two pretty important joints that I think address most all of the issues that come up. Okay, it's my daughter, the one on the right, and the one in the back of the boat there. She was a rugby player, and was a pretty good one, actually. And was a good rower, too, but she didn't like that rowing because she had to get up at 6 in the morning, or no, actually 4 in the morning, I guess, to get out to there and practice at 5 on the lake, and then come back to go to class when she was at Oregon. Anyway, here's a bunch of articulations right here in your neck. These are articulations that all bend a little bit, and you don't want this to happen. This is a patient with a fractured neck. You notice that the bodies of the vertebrae come down here like that. And remember, if these are the bodies, then the spinal cord is running right in here between this, the back of the body, and the front of the lamina up here. So I think there's a line you can kind of make out goes down there. And then all of a sudden it gets down to this point, and you notice that it went like that. And when that happens, it usually severs the spinal cord, just cuts it, because the spinal cord itself is not all that tough of stuff, you know. And so this patient here is paralyzed from that point down. Not only can they not move anything from that point down, but they can't feel anything from that point down. It's a tragedy. I think I've given you guys the talk about adjusting your headrest in your car. It's a simple thing to do. It's the most important thing in your car that prevents you from having a fractured neck. If you slam on the brakes, it's not so much that we have airbags now, and we have padded dashboards, and we have non-fracturing glass. We didn't used to have any of those things. We also have seat belts. We didn't have those either. Those are all designed to take care of you when you fly forward, but the headrest is the only thing that protects you when you fly back. For every action, there's a reaction, you know, all that stuff. So adjust your headrest. It just takes a second, and then once you do it, it's pretty much good forever. Guess I better not use this keyboard or use this other one. This is another example of a fractured neck. This one's down at the T7 level, I believe. 1, 2, 3, 4, 5, 6, 7. So 7 on 8 is all fractured. And it looks like this piece of bone here has gotten thrown back into the spinal cord. And this person here, because it's T7, should be able to use their arms. So this is a paraplegic guy who is one of those wheelchair racers, you know, that can become a wheelchair racer. It's such a wonderful thing. Every level you get is so valuable to you in terms of use of your upper arm. But I think the point to note is that anybody that's got a fractured neck struggles because they have no control of their bowels, they have no control of their bladder, they have no sexual function, they have no feeling down there. So it's really a tough thing to take. Take care of your neck, I would say. And don't let your kids play football. That's a stupid thing. But anyway, you will anyway. So here we go. Let's talk about articulations. Articulations are just the places where the body movements occur. They are where, also you can call them joints if you want. That's where two bones connect. And we have different kinds of joints because some of our joints are very movable and some of them are very immovable. I think the point of the matter is the way the joints are structured determines how much they can move. The more they move, the less stable they are. That's one point you should walk out of here with, and that is that the more mobility of the joint, the less security or stableness of the joint. That's why your shoulder, which has the greatest mobility, is also really your weakest joint, and people dislocate their shoulders a lot, have all kinds of problems with torn ligaments and so forth in their shoulders as well. There's two ways to classify these joints. I don't hold you to this because I just think these words are silly. Some of them are movable and some of them are not. That's about all you need to know, isn't it? The functional classification is based on this amount of movement. Structural talks about the anatomic organization, and you'll see in your book all these lists of different types. Here's one of the lists. Synarthroses, amphiarthroses, and diarthroses. I think I don't learn those words because I just don't think they're important. But just so you know, synarthroses means a joint there's no movement. So like the sutures in your brain up here, they don't move at all, right? The two bones touch, they fuse, they don't move at all. Same with your pubic symphysis down here, same with your iliosacral joints back here that make up your pelvis. They aren't designed to move. They may actually fuse over time. Most of them do. Amphiarthroses are very little movement. Your teeth are actually a joint. They would fit into that. You can actually move your teeth a little bit. I don't know if you've pulled on them lately. Diarthroses are the freely movable joints. They're the joints we think of as joints, and they're the ones we're basically going to talk about. They're also called synovial joints. The reason they're called synovial joints is because they're full of synovial fluid, and they are aligned with a synovial sac, a joint cavity. I'll just leave that one away. There's a couple of examples of not very movable ones. Sutures in your head, gomphoses. Gomphoses is a word maybe you ought to know because that does come up once in a while in terms of your teeth. Let's just move ahead and talk about the most of the joints that we want to talk about are amphiarthroses. They're more movable, and symphysis is a word that means a fusion of the bones. Usually it's a symphysis would be like the symphysis pubis, which is where the two halves of the pubic bone merge together in the middle. And I'll just leave that at that. Symphysis? Symphysis. Synovial joints are the main ones we're going to talk about here today. They're called diarthroses. They're also called movable joints, as you can see from that little slide. And they're lined with synovial membrane, as I mentioned. What is synovial fluid? Well, synovial fluid is basically the oil, the greasy stuff that's in the joint. It's very, very slippery. The proteins that are in it are called proteoglycans. They're made by fibroblasts, just like lots of things are made by fibroblasts. The function of the synovial fluid is to lubricate the joint so that it can move back and forth for your whole lifetime, hopefully. It also helps distribute nutrition around to the different areas of the inside of the synovial fluid. It carries sugar and things like that. And it also acts as a shock absorber. Just by having fluid in there, it's kind of a mild shock absorber. And we're going to talk about other shock absorbers like cartilages and fibrocartilages that are in your knee. But just remember that the fluid itself forms a minor bit of a shock absorber as well. We'll talk about some of the components of these joints because most, it's not just two bones, the two ends of two bones sticking together and have a little capsule around it and a little greasy fluid there. There's also other things that help hold it together and make it work. The one you really need to know about is the fibrous cartilage pads found in your knee called the meniscus. Now just remember that a meniscus is a cartilage, it's fibrocartilage, and there's a pad of it that's in your knee. There's actually two of them. There's a medial meniscus and a lateral meniscus. Anybody here had surgery on their meniscus? There you go. I've had it on both of my knees. I think it was probably from me running an awful lot as a younger person and then doing twisting kind of things in different exercise classes. And I think that the edge of my meniscus kind of got folded up and then got crunched between the two bones and torn. And it's called a torn meniscus, obviously. And you remember about cartilage. Cartilage does not heal, right? Because it has no blood supply. And so we've talked about that at several points this term when we've talked about cartilage. Well, it's true here too. So if you get a torn meniscus in your knee, you're looking at surgery to take that piece out. Usually there's a little rip and in the cartilage, and that piece that's ripped then folds under. And so when you bend your knee, sometimes it gets caught and you can't move your knee at all. Or you finally get your knee straightened back out and that thing unfolds, but it hurts like crazy. And it does damage to your knee, so you want to go ahead and get it fixed if that's the diagnosis. And with mine, all they did was they just went in and they took out part of the cartilage, they shaved down the edges and make it nice and smooth so it won't fold under anymore, and that fixes the problem. There's also fat pads around the joint. They are outside, superficial to the joint capsule, and they're designed to protect your knee and your cartilages and so forth as well. I'll show you some pictures in a minute that have some fat pads in it. Probably one of the biggest things that supports our joints is our ligaments. Now, the reason that our knee sits there where it does and doesn't move off the bottom part here. This part and this part stay together. Don't go this way, they don't go this way, and they don't go that way. Is because there's a bunch of ligaments in our knee, which I will go through for you here in a while, because that's one of the two joints I want you to know. But ligaments, you remember what ligaments are? What's the definition of a ligament? Bone to bone. That's right. Ligaments are bone to bone. They are really, they're, what kind of connective tissue are they? Dense, regular, right? Dense, regular. And so whenever you have a sprain of a ligament, he sprained his ankle. What that really means is he tore some of the ligaments in his ankle. By definition, an ankle sprain means torn ligaments. Now, you're lucky in your ankle because you have a whole bunch of them and you can tear a few of them and your ankle will still work okay. There's a few ligaments in your knee, however, you can't really do without. And if you tear some of those ligaments, you're going to have surgery and have to have the ligament fixed one way or another. Okay. And the way you know that they have a sprained ankle is if you can see blood under the skin. So if you twist your ankle and it doesn't turn black and blue, you didn't sprain it. You didn't tear any ligaments if it didn't bleed at all. Okay? That's the definition, really, of a ligament. Of an ankle sprain. An ankle sprain is a torn ligament. And the way you know whether it's torn or not, because usually you can't see it on x-rays at all, and on CT scans and MRIs you can sort of see it. But in the ankle, it's hard to. But the way you know is if it's turned purple. You've got an ecchymosis under the skin, blood under the skin. Other accessory structures are tendons. What's a tendon by definition? No, not muscle to muscle. Muscle to bone. That's right. So you have a bunch of muscles here that a muscle attaches to bone. But in the process, that tendon actually strengthens the joint as well and serves as support for the joint. We'll learn about a number of those. Bursa, you've heard of people having bursitis, tennis elbow, all kinds of bursitis. Bursitis is just an inflammation of a bursa, And a bursa is nothing more than a little sac of synovial fluid that are just in different places just to cushion the areas. Sometimes they cushion where ligaments and some place where tendons come, so that the tendon can roll back and forth across there and not apply too much pressure to any one particular area. I'll show you some examples of that. So, all of these things are things that stabilize synovial joints. All of these capsules, all the ligaments, articulating surfaces. Sometimes, like the elbow, you remember the elbow, the ulna is shaped like this, and it kind of fits into this thing up above. Well, you get an awful lot of strength in that joint because it can't move, because it's built in there. So that's these articulating surfaces are one of the things that really do give a lot of strength to your joints. Other muscles, bones, and tendons hugely impact the strength and stability of your joints. So here's a picture right here that's sort of a generalized picture of a synovial joint. And let me just point out that the things that you see in this picture occur in every joint, whether it's between two of your fingers here or whether it's your knee. They have bone, epiphyseal line, spongy bone, marrow down here, medullary cavity. And then on the end of the bone, of course, is hyaline cartilage, right? Old hyaline cartilage. Not only is it real slickery and allows it to roll back and forth, but it also affords some cushioning as well. This cartilage does give a little bit. In here is the synovial fluid. This is the joint cavity illustrated in red here. And so this line out here that goes around the outside of that cavity is the synovial membrane. Synovial membrane, the joint membrane, secretes the synovial fluid, which fills this cavity. That make sense? Here's another one. This is actually a knee here, and this one is a little more complex. And this is one of the ones you really should concentrate on in your studies. Here's the femur up above, which is your thigh bone, right? Here's the tibia down below, which is your shin bone. And remember that the lateral bone down there is called the fibula, and the fibula does not participate in the knee joint at all. It's way out there on the side. It articulates with the side of the tibia, but it does not it doesn't participate in the knee joint. There is another bone that does participate in the knee joint, and it's called the patella, right here. Okay. So, a couple of things. Let's just talk about these things. Here's some fat pads. There's fat there, and there's fat back here that kind of fill in the empty spots in between some of these tendons. This is the big quadriceps tendon that runs down the front of your thigh up here, and it separates and kind of encloses the patella. Remember, the patella is a sesamoid bone. That's the type of bone it is. And then the patellar ligament, which is the one the doctor thumps with his little hammer when he's checking your reflexes. And notice that it inserts down here into this big bump on the front of the tibia, which is called the tibial tuberosity. Notice that behind the tibial, this tendon right here is a little green sac right there. That's a bursa. Okay, it's just a little sac in there to help with things rubbing over it. Here's another bursa out in front. So and here's another one. This is called the prepatellar bursa. It's out in front. And for those of you, I don't know how many of you have pain when you kneel down on your knees. That's probably from a little bit of bursitis in your prepatellar bursa. It's really not in your knee. It's in your bursa. So back here on the back, here's another little bursa. You don't need to know the names of any of these. Just know that little extra sacs of synovial fluid are bursa. Here's the joint capsule right here that forms the knee joint, and it's full of synovial fluid too. Now just remember that the knee has a couple things in it that most joints don't have. One of those is the meniscus. Here's the meniscus. You see it's kind of a wedge of cartilage back here. And here's the other part too. Now there's actually a medial one and a lateral one, but they kind of show up one more anterior than the other. But if you're standing at attention and you're in the military someday and you lock your knees back there, push your knees back as far until they lock, okay, which is the way a lot of us stand all the time, is with our knees locked, which is not very healthy, by the way. You should always have your knees bent a little bit. Keeps you from passing out, too. Keep your knees bent. But these are the menisci, and they're made up of the fibrocartilage, like I said, and these are the ones that can get torn, and then they have to go in and shave them off or take them out. Also notice that within the knee joint there are these things called intracapsular ligaments. Now, I'm sure you've heard on TV, this guy, he ruptured his ACL, his anterior cruciate ligament, or his PCL, his posterior cruciate ligament. Those are the two ligaments that actually go right through the joint. Okay? It's just a piece of tendon that attaches. An ACL attaches right up here to the front of the femur. It comes across through the joint itself and then inserts back here on the back of the tibia. I'll illustrate that to you later in a little video that I made. So just know that the knee has some intracapsular ligaments that are actually loose in the joint. Joints can be dislocated, and a dislocation is really when the bones just come out of joint. Okay, I was riding with my daughter-in-law on bicycles, and she fell, landing on her wrist, I guess, and she couldn't move her arm either. She couldn't move her elbow, couldn't either open it or close it, and it looked kind of wonky, to be honest. You know, when you pulled her shirt back, you could see that her elbow just didn't look right. Well, we didn't know whether she had broken her elbow or whether she had just dislocated her elbow. So what do? You take her up to the emergency room, and what do? They look at it and say, we need to x-ray your elbow. And as a lesson to all of you future x-ray techs, don't treat your patients like they treated my daughter-in-law up at OHSU. He says, okay, we got to get this x-ray. Now you need to straighten your arm out. She said, I can't. It hurts. Come on, straighten your arm out. And she starts crying, and I finally had to step in and say, listen, buddy, you don't know whether that bone's broken or not. You don't know whether it's dislocated. Just take the x-ray like it is. And sure enough, the little hook of the ulna wasn't on the trochlea of the humerus. It was like out there to the side and completely out of joint. Well, of course she couldn't open a wrist or elbow and bring it back. And so, but the good thing was none of the bones were broken. There were no fractures. Well, that makes it a lot simpler problem. And what they did was they just sedated her, got her really sleepy, and then a guy took her arm and pulled it out, put it back in joint, and she was fine. And instantly, the pain was gone, and really within 3 days, she could move her arm normally again. So, but you had to know that it wasn't fractured, so you had to have an x-ray. And so sure enough, then they took another x-ray to make sure that it was in joint and everything seemed fine, and it did, and she did fine. So, a dislocation is also called a luxation. It's just another word for it. A subluxation is kind of a partial dislocation. And you've seen people who dislocate a finger, they'll just take and pull it out and put it right back in joint. But a subluxation is just a partial dislocation of a joint. We need to know some words here, and please pay attention to these because these will be covered not only on the practical exam but also on the written exam, okay? Now, what is flexion? You'll also need to know these words because when we talk about what do muscles do, this muscle flexes the elbow, for example. So a flexion is an angular movement it reduces the angle between the elements. So the angle here is 180 at elbow right now, and if you flex your elbow, you're turning it into like 90 and now into about 60 degrees, right? So that's, this movement here is flexion. This movement here, where you extend your arm, is extension. It increases the angle between the elements. Now, gee, that was really simple, wasn't it? Yeah. All right, so what's flexing the hip? Well, flexing the hip means moving your thigh forward. That's flexing your hip, okay? This is extending your hip. Flexing and extending. What's flexing your knee? Flexing your knee is bending your knee and extending your knee. Got it? Because as we get into studying the muscles, which we're going to start on next week, those will all become very important as to what mechanism or what action does this muscle cause. So here's a picture that helps illustrate some of those things. Here's flexion and extension. So here's flexion of the wrist, flexion. Here's extension of the wrist, right? What's hyperextension? Hyperextension is going farther back than straight on, okay? So here's flexion, here's extension, here's hyperextension. Same with your neck. Here's flexion of your neck, here's extension of your neck, here's hyperextension of your neck. I think that covers all of those little hummers there. Another thing you've got to understand is adduction and abduction. Now, I'll tell you that on the wards, when we were talking about patients, and we would say, well, the lady can't adduct her knee, or she can't abduct her hip or something. We would usually say it, instead of just saying adduction, we would say adduction, as opposed to abduction, to make it more clear as to what you were saying, because they both sound so much alike. So, the way to remember it is adduction is moving things towards the middle. In other words, it's adding to the middle. Okay? Abduction is moving things away from the middle less. It's sort of subtracting from the middle. But just remember, adduction is moving in. So, this movement right here, from out here, my leg out that direction, into here, is adducting my thigh. This is abducting my thigh. Now, this is adducting my arm. This is abducting my arm. Now, why is that important? Well, you're going to find that there's a whole bunch of muscles that are called abductors and are called adductors. So there's a bunch of muscles here in your thigh that are called the adductors, and this is the movement that they do. They pull your thighs into the middle. Abductors, there's some abductors out here on the lateral side of your thigh that pull your leg out. Okay? Couple of special ones. Adduction is putting your fingers together. Abduction is spreading them out. Now, why is that special? Well, look at it. I'm in anatomic position. And I've got my fingers together. When I spread my fingers out, some of my fingers moved away from the midline. Some of them moved towards the midline, right? Get it? That's why we just say that when you're bringing your fingers together, that is adduction. When you're moving your fingers apart, that's abduction. Even though they're not really moving towards the center or away, some of your fingers aren't. They're moving in the opposite direction. Does that make sense? Okay. So adduction is pulling them together. Abduction is moving them apart. This one's called circumduction. I don't know what the use of that word is. Just unless you want to make circles on a chalkboard, I don't know what else that does. We have some rotational movements that are also very important. Rotating your head, obviously, back and forth, right and left. Remember that most of your head rotation occurs between C1 and C2. That's right. Remember the little odontoid process. And then we have medial rotation and external rotation. That's where we turn our arms one way or turn our arms the other way. Okay? External rotation means moving your hands out or rolling them out like this, whereas internal rotation is rolling your arms in. Same with your legs. Okay? Internal and external rotation. Now there's another couple of them that have to do with your hand, and really your hand only, and that's called supination and pronation. Okay? So looky here. This is supination. This is pronation. Supination, we have supinator muscles that are in our arm here that make us supinate like this. Now the way the book says to remember this, and I have to tell you, it's the way I remember it too, is when you supinate, it's so you can hold a bowl of soup. Okay? Supinate. Pronate, this way. There's a pronator teres, there's a pronator brevis. Those are muscle names that do those maneuvers. Okay? Pronation and supination. A couple of special ones here for your feet. One is called plantar flexion. Well, I guess I should do them in order here. Eversion and inversion. When you invert your foot, you roll your foot in, so you'd be walking on the outer part of your foot. If you inverted your foot, if your foot is turned out so that you're walking on the middle part of your foot, the medial side of your foot, that's called eversion. Eversion, inversion. And just so you know, if you're a runner and you run a lot, you know that shoe fit is incredibly important. And most companies used to always evert the feet a little bit. I believe I'm saying this right. They used to evert the feet a lot. And one of the things that made Nike what they became is that their shoes were built so that they inverted your foot a little bit. And people found that with your foot a little bit inverted, based on the shape of the sole of the foot, you could run a lot better. And so that was one of the things that led to them, becoming the biggest shoemaker in the world. Inversion, eversion. I think Adidas shoes tend to evert you. Nike shoes tend to invert you a little bit. It's just whatever feels good to you. And if you ever get the opportunity, if you are a runner, to get on one of those treadmills that has video on it, some of the shoe stores in downtown Portland have that, where you put on the shoes and you run, and they videotape you for a while, and then you can actually see how your foot is landing. It helps with this eversion, inversion thing. Okay, plantar flexion. The plantar surface of your foot is the bottom of your foot, right? What do we call this surface of your hand? Palmar surface, right? Palmar and plantar. So if you dorsiflex your foot, it's pulling your ankle up, right? If you plantar flex, it's pointing your toes. So step on the gas pedal, you are plantar flexing. The last motion that you need to know is the motion of opposition. And it only affects your hand. And we have what we call opposing thumbs. Okay, we can take our thumb and touch the pad of our thumb, the most sensitive part of our thumb, to all of our other fingers. We have opposing fingers. No other animal does. Monkeys their hands are kind of like this. They really can't do fine manipulation like we can with our hands. And that's enabled us to, build tools and make computers and all kinds of other stuff. But opposing thumbs are incredibly important, and a lot of that is because of our thumb is so amazing itself. If you think about everything you can do with your thumb, leave it at that.
Another few movements here are related to your jaw. I'm not sure how important they are unless you're a dentist. Protracting means moving your jaw out, and pulling it back is retracting your jaw. Depressing it is opening your jaw down, and elevation is biting or raising it back up. And I think a lateral flexion is obviously bending your neck. Let's talk about some of the shapes of joints a little bit. These make sense, so I think you probably ought to know these. You know, gliding joints are just bones that just kind of glide over each other. For example, your carpal bones in your wrist. Okay, you know, there's 8 of them in there, and they all just glide a little bit. But when you put all of those little bit of gliding together, it gives you pretty good range of motion of your wrist. Hinge joints are only work in one direction. A couple of good examples is your elbow. Your elbow only bends in one direction. You can't take your hand and move it out there to the side. You know, if you're stabilizing this joint here, you can rotate it and get it out there, but you can't move it sideways. It's a hinged joint, right? Same as your ankle. Your ankle is up and down only. It doesn't go out to the sides at the ankle joint. Pivot joints are ones that rotate only, and the best example of that I can think of is the head of the radius. Remember the head of the radius, which articulates above with the capitulum of the humerus. Remember that? And it just rotates. That allows us to do this. Cute little pictures. I don't think they add a whole lot. I'll just leave that go. There's some good examples. You ought to look through those. I think those are helpful because these are words that you do use. You know, pivot joint and hinge joint and so forth. Ball and socket joints are the best ones of all. They're the ones we're going to spend some time. When we talk about the shoulder, we'll be talking about it. The ball, which is on the end of the humerus, sits into the socket, which is the glenoid cavity on the scapula, allows our arm to do all of this stuff. Our hip bone is another ball and socket joint, although it doesn't have quite as good a range of motion. And this is the point that I've already made, and I just want to be sure I beat this into you, that a joint can't be both mobile and stable, okay? So what it gives up in mobility, it gains in stability, and vice versa. Let's talk just a second about those intervertebral articulations. Remember that your spinal cord is running right down here between the back of the body and the front of the lamina, right? And so this is the protected zone right in here. And in order to protect that and keep that area open, we have lots of ligaments that we don't really see much in our class here or in lab, but you can see them in this picture here. You have anterior longitudinal ligaments, you have posterior longitudinal ligaments that run right in there. You have a bunch of interspinous ligaments that go from spine to spine here, and you got lateral ligaments down the sides and so forth. But just know that there's lots and lots of ligaments surrounding your spinal column that give it a lot of strength. Obviously, your spine doesn't move all that much. You know, in order for me to twist my shoulders like this, I'm using 20 different spines, spine on spine joints to make that happen. Each one of them giving just a little bit to allow me to twist my spine. That makes them very strong because they're not very mobile. Slip disc is usually, that's an interesting term. It doesn't really slip, it really ruptures, it bulges out. It's a bulge in the annulus fibrosus where the annulus fibrosus then sticks out into the vertebral canal. We have a couple of models over in the lab of the spine that show a really nice bulging disc or a ruptured disc. And you can see that when it ruptures out, it pushes on the nerve that's at that level. So generally, you can figure out what level a patient has a ruptured disc by talking about their symptoms. Exactly where does it go down your leg, which side of the leg, how far down the leg, to figure out which nerve it is that's being pushed on, whether it's L2, L3, L5, like that. A herniated disc is really when it just bulges out there. That's really when it gets bad. Here's a picture of it. Here's the slip disc right here, and like I said, we have nice models of that in the lab, and they tend to show up on practical exams. Here's an example from above. Here's the annulus fibrosus that would normally go all the way around the disc, but you see it's ruptured out here, and this is where they usually do rupture, and then the contents of the inside of the disc push out there and push on these nerves, as illustrated there. Basically, the movements of the vertebral column are minimal at each level, but together they can be quite a bit. Flexion, extension, lateral flexion, rotation. I think that's enough said. Let's talk about the glenohumeral joint, which is the fancy name for the shoulder joint. It has more motion than any other joint, and because of that, it is the least stable of all of our joints. It is really supported mostly by muscles, tendons, and ligaments. It is a ball and socket movable joint, or diarthrosis, and it is basically a joint between two bones, the head of the humerus and the glenoid cavity of the scapula. But you guys have looked at that glenoid cavity, and you know it's not very much of a cavity, right? It's maybe that much is all it is. Now, when people dislocate their shoulder, they can dislocate it anteriorly, in which case the bone pops out this way off of the glenoid, or they can dislocate it posteriorly when it goes off the back. And I think posterior is a lot more common. Usually it happens when somebody's got their arm up and somebody hits them on this side right here, and that causes an anterior dislocation. The head of the humerus comes out forward, and then when it's posterior, they're hit like this, and it pokes out the back side. Most shoulder dislocations can be fixed by just pulling it out and putting it back in socket. I'll talk about that in a minute. I remember LaMichael James. He was a running back for the Ducks here a couple of years ago. He had dislocated his shoulder a couple of times in his high school and way back career, and he's got the ball in his hand. He jumps into the pile, and he's being tackled, and all these guys are working on him. And you look in there, and they show him. He actually reaches down, grabs his arm, and pulls his shoulder out while he's still in the pile. He put his shoulder back in joint, and then of course he had to come out because it hurt pretty much. But he went back in a few plays later. The point being that the shoulder dislocates pretty easily, and if you dislocate it once or twice, it gets easier and easier, both to dislocate and to relocate. One of the things about the glenoid, and this is what I wanted to talk about, is that one of the things is because this is such a shallow cavity here, we have this thing called the glenoid labrum. The labrum is kind of like a lip around it. So the glenoid labrum kind of comes out like this on each end like that, and sort of makes the socket a little bit deeper, okay? And it deepens the socket, it's fibrous cartilage, and it extends out past the bone, just like I drew it here. So now that bone, that humerus, has a little bit more of a socket to sit in, okay? The acromion, remember the acromion? Acromion attaches to the clavicle, the AC joint, acromioclavicular joint. It projects laterally and sort of protects the shoulder joint a little bit, but it doesn't really protect participate in the shoulder joint. It does help stabilize it because there's a bunch of muscles that are attached all around there that help hold that shoulder in. So here's a bunch of ligaments. Please don't memorize all of these because you don't have to, but they make kind of sense if you think about them. The glenohumeral goes from the glenoid process to the humerus. The coracohumeral goes from the coracoid process to the humerus. Coracoacromial goes from the coracoid process to the acromial process. Coracoclavicular goes from the coracoid process to the clavicle. And the acromioclavicular, the AC joint, which is basically your separated shoulder, is your acromioclavicular joint. Shoulder separation is basically separation of the acromion and the clavicle. Okay? This says it's dislocation of the shoulder joint. Not really. Dislocation of the shoulder joint is when the head comes out. Shoulder separation, I've always thought it was just a tear of the AC joint. Now, the other thing that really helps the shoulder and keeps it stabilized is that you have all of these muscles. So you've got these muscles. One, the supraspinatus. Remember the supraspinatus? It lives in the supraspinous fossa. Remember on top of the scapula back there? You got the infraspinatus, which comes from below the spine on the back. You got the subscapularis, which comes from the subscapular fossa, which is the front side of the scapula. Remember, it goes up here to the shoulder, and then the teres minor is another one that's attached to your arm. So all of these muscles are basically holding things in here, but the muscles themselves are tending to stabilize the shoulder joint and not allow it to come out of the shoulder joint. Bunch of bursa around. Don't worry about naming them either.
So we need to know the shoulder muscle.
Well, you will next week.
But not for the test.
No, ma'am. I don't know. I mean, you ought to know the name of it. You don't know where the infraspinatus muscle comes from, right? But you know the name of the infraspinous fossa, supraspinous. You know that one.
Yeah.
Okay, there you go. Here's those ligaments that we were just talking about. Here's coracoclavicular. This is the coracoid process. Remember, here's the acromion process. Here's the AC joint up here. This is your separated shoulder. Here is a bunch of, this is the shoulder joint itself right here. Here's the labrum that's built up right here and over there on the other side as well. To make the cavity a little bit deeper. But the concept I want you to have is that there's all these muscles that go around the outside of this that are all basically supporting the shoulder, keeping it in joint. Here's a nice little picture of the inside of it here. You see the scapula back there down at the bottom of the picture down here. And then notice that this muscle here just so happens to be the subscapularis muscle. This muscle here just happens to be this is the teres minor, but there's also a supraspinatus and infraspinatus muscle that come in there too to help form around the shoulder joint. Notice there's ligaments here that run right through the joint here as well. Tendon of the biceps. Remember, the biceps muscle is this one here in your forearm, here in your arm rather, and that muscle comes up, goes over the head of the humerus, and then plugs into the shoulder. That also gives it support. Enough said about that. Okay? Please know you don't have to learn all the muscles, but do understand the concept of the labrum, and do understand the bunch of muscles that help shoulder it. Torn rotator cuff. You need to look in your book and understand the term rotator cuff. Okay, the rotator cuff is a group of muscles that attach around the shoulder to help hold the shoulder in the joint. And you'll hear about that on TV all the time. Oh, he tore his rotator cuff. And you'll understand what that means. We can actually show you those in the lab as well. The elbow joint, just real briefly, basically is the humero-ulnar joint. Remember the humerus and the ulna, and there's that hook that has the olecranon process, the big one, the coracoid process on the front makes the hook. So that's the largest articulation between the trochlea of the humerus and the trochlear notch of the ulna. There's also the humeroradial joint. Remember where the humerus touches the head of the radius. It does it with the capitulum of the humerus, that round thing that sticks off the end of the humerus, and the head of the radius. And it's just strictly a rotatory joint as well. Bunch of ligaments, please don't memorize them. There they are, radial collateral, there's ulnar collateral, there's all of these guys. Remember this radial tuberosity. What attaches to the radial tuberosity? Biceps muscle, that's right. I'm going to just slide through those. Whole bunch of ligaments that we could get you to learn, but I just think it's important that you know that there's lots of ligaments. And to rip your elbow out of joint is pretty tough to do, but it can be done. Let's go to the hip. This is another one that I don't expect you to go into great depth. Just know it's called the coxal joint because remember it's the coxal bone. And the coxal bone, remember, is formed of 3 bones. And they are the ilium, ischium, and pubis. That's right. It's a very strong ball and socket joint, has a wide range of motion, but not as wide as the shoulder, as I've mentioned. Lots of ligaments down here. Once again, please do not feel like you need to memorize all of those. You should know a couple things. One thing is that the hip joint, the head of the humerus fits pretty deeply down into the acetabulum, which is the name given to the hole in the side of the coccyx. There's some fat in there. There's a little ligament called the ligament of the femoral head that you see here is kind of a loose. It's a ligament that's sort of loose in the joint once again in this one. And we'll see. I'll show you where it attaches, but it attaches to that little dimple on the head of the femur. What's it called? Yeah, the fovea. Is that right? Fovea capitis. Capitis, the head, yeah. Bunch of ligaments here that totally strengthen your hip joint. Your hip can be dislocated, but believe me, the hip doesn't dislocate near as often as it fractures because the ligaments are pretty strong. Here, just an example. Remember your greater trochanter and your lesser trochanter. Here's your ischial tuberosity. Remember, that's what you sit on, your ischial tuberosity. And now let's talk about the knee joint, because it's the best one to talk about of all. It's also the one you'll read about. You'll hear, if you ever watch sports of any kind, they'll be talking about injuries. And most injuries in most sports, especially in football, have to do with the knee, by far and away. And if you think about what your knee does, you know, it's basically just one bone sitting on top of another bone, right? That's a pretty weak setup, you know, because it can get knocked off in any direction or bent in any direction that it's not supposed to bend in. It's only supposed to bend in one direction, front to back, right? If you bend it too far out and hyperextend your knee, that's a bad injury. You bend it too far back, but most injuries of the knee are caused by getting hit from the side, either the lateral side or the medial side, and tearing these ligaments that are just there holding these two bones together. Okay? Remember that all of the bones, all the weight transfers from the femur down to the tibia. 100% of your weight is carried by your tibias.
Okay? Articulations of the knee joint, there's basically two, remember the two little knobbies on the end of the femur there? Those are the two femur to tibia articulations that work, called the medial and lateral condyles. Then there's also another joint, another articulation between the patella out here in front, and the patella touches the patellar surface of the femur as well. If you just play with your bones a little bit, that'll all become very obvious to you. The menisci, I've already mentioned them a little bit. They're these fibrous cartilaginous pads that are in your knee that work really well for us, but they can get torn. And when the cartilage gets torn, it's a problem to you because it gets folded and gets stuck in there weird. They're there to help cushion the joint, but also to help stabilize it. And if you'll look at the models that we have over in the lab of the knee joint, you'll see that the menisci aren't just sitting there mindless. They're kind of molded in such a way that it actually adds to the, I won't say it makes a ball and socket out of it by any means, but it does tend to make a little bit of an edge to help keep those bones lined up in the way they're supposed to be. Locking your knees, which I mentioned before, means standing with your legs straight back. And the reason it does that is it locks that the lateral meniscus between the tibia and the femur. And that's why it stops at that point. It's because they're right up next to each other. There's 7 ligaments of the knee joint. I'd like to show you a little video that I made that I think explains this better. But you do need to know all 7 of these. So keep that in mind. Let me just go over them real quickly right here. First of all, there's the patellar ligament. The patellar ligament is the one that comes down the front of your knee, and obviously that keeps your knee from going too far forward on your tibia. Patellar ligaments in front. You have 2 popliteal ligaments in back. They kind of cross back and back, the 2 popliteal ligaments. You have anterior and posterior cruciate ligaments, which are really hard for me to explain to you until I did it on this video. There's a tibial collateral ligament. The tibial collateral ligament runs down the medial side of your leg and inserts into your tibia, and it keeps your leg stable this way. And you have a lateral collateral ligament out here, or called the fibular collateral ligament on the outside that keeps it stable on the outside. That's the 7. And that's really that's the only things that give us our knee any stability at all is those ligaments. So that's why when you break one of them or you tear one of them, you sort of got to get it fixed. Otherwise, you got a very, very useless knee, or at least a knee that won't take much in the way of stress on it. So here's a couple of pictures. Here's the patellar ligament, the quadriceps tendon, patellar ligament. It kind of splits in a way so that when you bend your knee, those 2 retinaculae here kind of go around on either side, also to give it strength. Here's the fibular collateral ligament over here, called the lateral collateral ligament. Makes sense? One on the medial side over here is the medial collateral ligament, or the tibial collateral ligament on the medial side. Picture from the back, I believe, is coming up. And from the back side, you can see the popliteal ligaments right here. One goes this way, one goes that way, to give the back of your knee some strength. Here's a popliteus muscle. Popliteus just kind of covers the popliteal space in there. Here's your gastrocnemius muscle. That's your big calf muscle in back. Notice it's coming off here. There's a bursa behind it. Here's the lateral head of the gastroc coming off there, and going down as well. Kind of a nice picture.
once again, I think if you look at the models in lab, they're really good. It'll make more sense to you if you do that. Now, we haven't talked about the collateral ligaments yet, the cruciate ligaments. Here's what they look like. Here's the ACL, the anterior cruciate ligament. Notice that the ACL attaches on the front part of the tibia out here. It goes directly through the joint and then inserts back here on the back side of the femur. The PCL does just the opposite. It attaches back here on the back side, but of the tibia, and comes up here and inserts back in there on the distal end of the femur. Once again, and you're probably wondering why they're called cruciate ligaments. Cruciate means cross, and they cross. That's it. That's it. That's the truth. I'll show you my little video here. Anyway, another picture showing the lateral meniscus there on this picture. See, the lateral meniscus is in here. Here's the medial meniscus over here. That's just that big wad of fibrocartilage that sits there between the joint. Let's talk about getting older. When we get older, our joints don't work so well. You can call it rheumatism if you want. That just means kind of pain and stiffness. Arthritis is really just, it's really damage to your joints. There's many causes of arthritis. The most common is osteoarthritis, which is simply is just aging. There's rheumatoid arthritis, which is a specific disease where your body attacks the joints themselves, and rheumatoid arthritis can be very disabling, although they're coming up with better treatments for it. The third one is called gouty arthritis. Gouty arthritis is pretty rare these days because now we have pills that can really make us just dissolve all the extra uric acid in our body, and so we can get rid of it or not make it. But gout is caused by uric acid crystals forming in your joints, and then when you get, it's like having sand in your joints, and it can become very, very painful with gout. Yeah.
The uric acid is a waste product, right?
Well, no, I would call it a metabolite. It's a metabolism product. Whether it's a waste product, it's you need some, you just don't need too much.
Is that when people get like those little lumps?
No.
You see little,
On their skin?
yeah, like you see little like lumps on the, and they usually have pain around.
On their joints?
On the joint.
That's rheumatoid arthritis usually. Rheumatoid arthritis can really curl people's hands up and give them big knobs sticking off. Rheumatoid arthritis is a bad deal. But treatments are radically improved over the last 20 years. Joint immobilization is not good for you. Going to bed and not moving your joints is bad. It causes your synovial fluid not to move around. Usually people that are at bed rest for a while are going to have to spend probably 3 times as much time rehabbing with physical therapy and so forth to get back to where they were. Our bones, as we get older, get weaker. We talked about osteoporosis earlier. This is where you really see it, is in the joints and the broken bones. I think I said to you already, you need to understand calcium metabolism. We come back to it over and over in A&P. My 232 class right now is about to take a test this week, and a lot of it is about calcium metabolism because we're doing with the thyroid gland and the parathyroid gland and the adrenal glands and the kidneys and all this stuff. They all play an important role in calcium metabolism. Obviously, the ovaries and testes do as well because they make hormones that affect our bone. So I would just tell you not to, even though you don't need to know it at the level you will eventually, just remember that you can't forget this calcium metabolism stuff. So that stuff about parathormone and stuff about calcitriol and calcitonin and all that stuff, even though we've only sort of touched on it keep it firmly affixed in your brain because it will become more important later on. And also remember, what was that? There's that vitamin D again. Remember that rickets stuff? Oh yeah. I think this is just kind of a couple of quick picture reviews that I'm done showing. That's a boat. Back in 1993, my wife and I went over to Zadar, Croatia during the Serbo-Croatian War to help the Croatians out a bit, and we went there and did surgery in the hospital for them. And that was, we were walking to town one night, and there's a little harbor there, and I thought that was such a peaceful place amidst all this killing that was going on. Very interesting. Okay, so let's not do that.